Cefepime-induced neurotoxicity, also known as CIN, was first characterized in 1999, but it wasn't until 2012 when the FDA issued a warning regarding cefepime use and renal dysfunction. Specifically, the GFR is less than 60. To this day, CIN still remains a loose clinical diagnosis, despite its increasing recognition. And conventionally, neurological symptoms start about 4 days after the initiation of cefepime, but have been reported to occur as fast as 1. And also typically, the symptoms resolve 3 days after cefepime discontinuation. So let's talk a little bit about how this happens. Cefepime acts as a concentration-dependent competitive GABA receptor antagonist. Thus, more cefepime increases excitotoxicity. This characterizes the clinical manifestations such as altered mental status, mild clonus, lethargy, non-convulsive status epilepticus, and ultimately coma. This may also explain why patients with CIN have a very poor response to anti-epileptic drugs and benzodiazepines. Although these are not set diagnostic modalities, it has been shown that EEG shows diffuse background slowing in about a quarter of cases. However, only 1.3% of all patients placed on cefepime develop any abnormal EEGs regardless of whether or not that is CIN. It also has been reported that a cefepime plasma trough level of 22 or over carries a 5-fold risk of neurological symptoms. So with that being said, let's talk about our patient. Our patient is a 67-year-old male with a past medical history of ESRD, status post-renal transplant 8 years prior, maintained on mycophenolate and tacrolimus. Now has subsequent chronic renal insufficiency, recurrent urinary tract infections, and type 2 diabetes mellitus, presenting to our hospital with 2 weeks of generalized weakness, subjective fevers, dysuria, dizziness, and multiple falls at home. On initial evaluation, the patient's vital signs were normal, and the patient was febrile. The patient's physical exam was grossly unremarkable and had an intact mental status and no abnormalities noted on neurological exam. CBC showed no leukocytosis, and the creatinine was at this patient's baseline after the renal transplant. UA showed 3+ bacteria, 3+ leukocyte esterase, and negative nitrates, and microscopic UA showed packed white blood cells. The patient was started on cefepime without renal dosing, and urine cultures later grew Pseudomonas aeruginosa that was sensitive to cefepime. 2 days after starting cefepime, the patient developed acute encephalopathy with significant lethargy. And to rule out an infectious cause, we did a lumbar puncture, which showed clear fluid and an unremarkable opening pressure. On top of that, CSF analysis showed lymphocytic phagocytosis, elevated proteins, and a CSF to serum glucose ratio of 0.73, which is within normal limits. A comprehensive workup followed for infectious etiologies that was all negative, but included antigen antibody testing and nucleic acid amplification testing for fungal, viral, and bacterial organisms, including a negative bacterial CSF culture. It's also of note that blood tacrolimus levels were normal. At this point, we decided to dive deeper into the charts, where we found that the patient 6 months earlier received cefepime for an infected old upper extremity arteriovenous fistula. At that point, they also developed significant lethargy and encephalopathy 3 days after starting cefepime. At this visit prior, they did have renal dosing. During that encounter, we also did an MRI which showed no acute abnormalities, and a lumbar puncture was deferred due to the family's request. We suspected CIN, withdrew cefepime, and the patient's symptoms resolved within 4 days. Now, at our current hospitalization, cefepime was immediately discontinued, and alternative antibiotics were administered. The patient regained baseline medication just 4 days after discontinuation of cefepime, completed their treatment for their UTI, and they were subsequently discharged home safely. So let's talk about why this is so important. Now, cefepime is being used more than ever due to proliferation of multi-drug resistant pathogens. At this point, clinicians must have a very high index of suspicion for CIN, as the only true treatment is the withdrawal of cefepime itself. Our case is the first case report of lymphocytic phagocytosis with elevated proteins, secondary to CIN without superimposed infection. But the take-home point is that since CIN occurs in patients receiving cefepime for an infectious cause, a resultant encephalopathy could lead a physician to take an LP to differentiate between the two.
30 seconds.
Thank you. Thus, CSF abnormalities in the setting do not preclude CIN as a possible diagnosis. In addition, this is also the first case of recurrent CIN in a patient with renal and non-renal dosing. Thank you so much to Dr. Pistalis and Dr. Tran at Airhead Regional Medical Center, my lovely wife, who's heard this 100 times, and the ACP, and I am grateful. Does anyone have any questions?